We are practicing good social distancing. We got the ruler out and he is 6 feet away from me, so we should be good to go. All right. So current state of the state, and this is as of, I believe this morning when I looked, there's 463 total cases in the state right now. I'll include a link in the recording, and then I can send that out to anybody else. But Johns Hopkins University actually has a really interactive map of the current spread throughout the world, really, and you can really pin down all the way into each individual county in Wisconsin and across the United States. You'll notice when you go into this, the big outbreaks are what they're called cluster outbreaks. So they're in small areas like Chicago, New York, where there's a lot of people that live in a dense population. If you look at Italy, most of their cases are actually in the population dense areas. Rome has the largest amount of cases in Italy, and that's because there's population dense. Where we live in Wisconsin, obviously not very population dense, so you know we're going to have less outbreak, less clusters, and things like that as well. Important thing I think for people to understand is that they're doing about 1,000 tests a day at the state level, and only 4% of those tests are coming back positive. So, and they're being very stringent on what they are testing and what they're not testing. They're not just testing anybody with a runny nose and a sore throat. You have to have really telltale signs of this virus in order to even get tested. And even of those individuals that are getting tested, there's only about 4% of them are coming back positive. So the saturation in this area remains extremely low. I don't think we need to pull back any of our cautions at all at this point. But again, for those of you who have maybe some anxiety related to this going on calls, the saturation is still extremely low in the state of Wisconsin. So far, there was 6 deaths. There was a 6th one announced today out of Dane County. That individual was in their 70s that passed away this morning. Winnebago County remains at 5 confirmed cases. They have about 40 to 50 that they're still waiting for test results. Outagamie County has 3 confirmed cases, Brown County 5, Calumet County 1, and then 0 in Waupaca County. So again, very extremely small numbers, and all of those individuals are in quarantine and abiding by their shelter-in-place guidelines as well. Again, updates in the state testing, they implemented that tiered system, so they're really only going to be testing high likelihood cases and cases that have unknown really other rationale as to why the illnesses are and they're critically ill. I'm on conference calls basically all day, every day, but one of the good percentages that I got out of a conference call yesterday was that about 90% of the cases in the state did not require any sort of hospitalization. So 90% of these cases are extremely mild, not requiring anybody even to go into the hospital and seek medical attention. So again, very minor amount of patients that are actually seeking attention at the hospitals. Update from the 2 healthcare systems in this area. ThedaCare, again, has visitor restrictions. ThedaCare Neenah has set up a tent to help with their surge plan. That's a 19-patient capacity tent that in the event the ER is overrun with respiratory patients, they would have all the equipment, supplies, and gear in those tents to treat about 19 patients at a time and do the testing and any airway treatments that they would need to do with that patient right in the tent outside of the hospital. So if that were the case, there would be a little bit different patient flow, but nothing that really impacts us right now. The question is, why doesn't New London have a tent outside? They're also gearing up for something like that, but they're not operational at this point, and they would not have the ability to go live quite yet, but they are working towards that type of model, that type of capability as well. TC Neenah, as far as I know, is the only one that if tomorrow there was a huge surge in patients, they could flip a trigger and get that staffed and ready to go. Big thing is testing supplies nationwide continue to be extremely low. That is really resulting of just not enough mediums to go around the country. If you think about if we're doing 1,000 tests a day times that by 50, and we're a smaller population compared to the rest of the nation, they're probably doing about 100,000 tests a day. So those testing supplies go, and they go quickly. So that's why you don't see the drive-through testing in this area. That's why you don't see EMS providers doing any sort of testing. So again, there's not a ton of testing supplies out there. I don't know who wrote this, but it says some patients in Browning County are being told they have corona but was never tested and sent home with orders to treat the symptoms. There's no way to confirm that they haven't unless the test is being done. They might be saying that you have similar symptoms, but there's no way to confirm it. It could be a litany of any other viruses that cause similar symptoms, including influenza. So I'm not sure where that information would have come from. Theta Care Clinic in Green Bay Road and Encircle Health remain kind of the areas that we're encouraging our patients to seek medical attention to. St. E's and Mercy Medical Center are also have specific areas where they'll be do testing and treatment, and I'll get to that in a second. Right now, no alternate destinations designated at this point. There was a question about PPE. I'll get to that in a second from Tom. Ascension, again, they were originally going to go through and do a drive-through testing model, but very small amount of availability of testing, so they have suspended that model. They have also developed a statewide capacity spreadsheet, so that all the hospitals in this region and really across the state are tracking resources. So they're seeing how many med-surg beds are available, how many ICU beds available, vents, PPE, that type of stuff. So we've done a really great job as a state in having the ability to prepare. We've had time to prepare because we haven't had the surge of patients yet. So I think as far as the state, we're very well prepared to handle a surge because we've had a good amount of time to plan, and we've also had a good amount of time to learn from our outlier states who have had a large capacity of these patients. So we're being very proactive with how we're tracking our supplies, how we're communicating within region and within the state, and I think it's going to go well in the event we have a surge. Again, very low numbers still in this area though. Ascension is also looking at some potential solutions to reduce ED volume. One of the things they're looking at is telehealth. So how can they implement telehealth for EMS to utilize in the field and do some triaging, a little bit more aggressive triaging in the field than what we have been doing currently with the no transport protocol that Dr. Westfall put in last week. They're also be doing some medical screening exams in a tent on a campus so they're working on those things as well. So they're working on the tent model as well for surge capacity, but nothing's in place quite yet. So one of the things I wanted to address, I wasn't sure if it was clear in our last meeting, and I had a handful of questions as well from individuals about this, but I made it hopefully a little bit more clear for everybody in the coronavirus guidelines document that's been periodically updated. So basically this is saying that we added in there the verbiage for advanced airway and made it a little bit more clear. So anytime you're doing a BVM ventilation, oral suctioning, endotracheal tube intubation, NEB treatment, CPAP, BiPAP, or resuscitation involving emergency intubation or CPR, we're donning full PPE. So if you're on a workable cardiac arrest, please put on your N95 respirator, your goggles, and your gown before you enter the scene, because those advanced airway interventions are likely on those types of calls, and those are the ones we want to be, anytime you're intimate with the patient's airway is when you have a high likelihood of being exposed to droplets. So making sure you have all the proper PPE on for those types of patients is really important, along with the NEP treatments and things like that. So nothing really changed with this other than a little bit more clarification on the advanced airway techniques and when we're supposed to be donning PPE when we perform those types of interventions in the field. So any cardiac arrest that's workable, you're going to need your N95 respirator, goggles, and a gown on, and obviously your gloves and everything else as well. If they don't have coronavirus, why are we donning full PPE for these calls? We haven't before. There's no good way to get a history on these patients if they're in cardiac arrest. So there's no way for us to perform a screening tool, and so there's not really a great way to screen these patients for full PPE or no PPE. So the guidance at the state level and the guidance from a couple other resources is that we should be being proactive with these as opposed to reactive or kind of sit and wait for results if we find out later on that they may have had a fever, cough, shortness of breath a few days prior. So. Question again, for P&Bs wearing full PPE, has that info been passed on to the fire departments and first responders? Not yet, but that's a good point. I will forward that on to everybody. Another question, what happens in the event that the patient colds during transport and you do not have enhanced PPE on? We were paged for a potential stroke yesterday and only went in with surgical masks yesterday. So again, you're going to perform your screening, so we'll get to what that screening is. If the patient's conscious alert when you get there, you'll be able to perform that screening and determine if the full PPE standards need to be donned or not. So base that off your screening right away when you get on scene. If you're unable to perform that screening with one individual, then you're going to need to go ahead and fully don the PPE standards. Should we be sending in one provider to initiate CPR if first on scene and then have one person don PPE so we don't delay the start of CPR? So I'm just going to go back to scene is safe. So make that scene is not safe until you have your full PPE on. So make sure you get your full PPE on, and then you can send both responders in and start CPR. Do we have these HEPA filtration devices for BVMs? Unfortunately, no, we do not have the HEPA filtration devices for BVMs, and they are completely out of stock anywhere we can look and find them. You are still safe if you're donning your proper PPE, so it's just an additional layer that is recommended, but not anything that's going to create or put you in any danger if you don't have that HEPA filtration on your BVM. All right. So a couple things are no transport update. So that's been implemented now for about a week. We've gotten a few questions here and there. Feel free to reach out to Heather or myself if you have any questions on what that should look like, what that is. Dispatch should be tracking this on a daily basis, and Heather's been tracking that in conjunction with dispatch. We have right around 8 last we looked. And then the County Communications Center has also been discussing some triage. So again, if we're at a surge event and we have a large amount of patients seeking medical attention, the County Communications Center are prepared and have been having some internal discussions with their legal department on what it would look like in the event they wanted to implement triaging within the county 911 system. So that means that they will be, if we're at that surge potential point, they would be actually triaging people to clinics and testing facilities as opposed to an ER and as opposed to just sending EMS every time. Again, we're pretty far away from anything like that because of the saturation in this area, but those discussions are being had and being had early so that in the event we want to pull the trigger on something like that, we're prepared to do so. We have a stock of HEPA filters at Station 2 for the vent, should work with BVMs. Again, that's really just for the ventilator at this point, so we don't have a ton of those, so we're going to keep it isolated to the vent. Is WPACA dispatch screening patients? Yes, they're screening patients. Mark had actually a conversation with their dispatch center coordinator. They are screening patients. The frustrating part, I think, for a lot of our paramedics is each county seems like they're doing something a little differently. We've been trying the best we can to make it as consistent from county to county as we can. So we've been having a lot of discussions with them to make sure that at a minimum they're asking those screening questions related to fever, cough, shortness of breath, and travel or contact with a COVID-19 patient. So that we've been working with them, but every county, as far as we know, has some sort of screening tool in place. But again, it varies from county to county, depending on where you are in a service area. Okay, here's the kind of the PPE update, that N95 update. So again, we're really encouraging you to utilize that scout method. So you're sending essentially one scout into the house first. That could be a first responder. That could be one of our paramedics on scene first. That could be R100. But we're just sending one person in, and then they're going to go through that screening process. So that Category 1 and Category 2 screening process. Katie put together some laminated documents that we can keep in the front cab of all of our ambulances so that you can bring that in with you so you're asking the questions very consistently and in a scripted way. And then from there, we can make a determination of whether or not we're donning full PPE or if we continue our patient care without that full PPE on. Question came in, are all GCA staff still symptom-free? Yes, as far as I know. We've been doing our symptom monitoring on a daily basis, and as far as I know, we haven't had any triggers, no. Please make sure you're keeping your PPE supplies close by you at all times. We've had a couple instances where I've found PPE in places that is not easily accessible, and so the supervisors tucked away, on the dash or in the center console or in the doors. So keep it on the cot or keep it on your person. So the N95 at least should be on your person at all times. And then goggles and gowns should be either on the cot if you want to throw them in your blue bag because that's more convenient for you. All we want you guys to have them with you at all times and accessible at all times. So if you perform that screening from that 6-foot distance and they trigger the questions to don full PPE, that you have it with you. You don't have to exit the scene and find what you're looking for. So the big thing is making sure you're prepared for these patients, making sure you have everything you need for these patients and not having to try to rustle around in your ambulance trying to find what you need to go in an emergent situation. Again, we really need to ration these. I sent out some N95 guidelines for everybody. I'll go through some of the important bullet points of that document that I sent out today to help you guys determine when you should be disposing of these N95s and when you can continue to use them. Just to give you some perspective, we did get a small shipment from the Strategic National Stockpile. I put in a request for 250 N95 masks, and I got 90. So they're rationing them at the state level, they're rationing at the national level. They're just not readily available for us. We're exploring as many options as we can. We're trying to get creative with where are we getting these from, but again, there's just not a ton out there right now, so please be responsible with this piece of equipment and only discarded them based on the guidance that I sent out today. Question, I only have one used mask. How do I get the allotted 2 masks we were supposed to get? Were they distributed already? Call your on-duty supervisor if they have a stock in R100, and they will run whatever out to you that you would need. So just get in contact with your on-duty supervisor next shift, and they will get you that second mask. So N95 discarding. So this comes right from the CDC. This is their recommendations for when to discard that N95 mask and when you can continue to utilize the tactic called limited reusing, which is a tactic we've implemented due to a shortage. And basically this says that if the lifespan of the respirator has exceeded 8 hours of continuous use, that means you had it on for physically 8 consecutive hours or 8 total hours, that you need to get rid of that N95 mask. There's also guidance out there that says do not exceed 5 reuses. So please track your time and track your reuses. If you exceed 8 hours of continuous use or have used that mask more than 5 times or 5 times total, then you need to discard it and work with your supervisor to get a replacement. If the N95 respirator, please get rid of it if you have determined that the patient needs an aerosol generating procedure. Again, reach out to medical control whenever possible to see if there's an alternative method to treat these patients' respiratory symptoms, because this is, again, we want to avoid unnecessary nebulization of patients and making sure that when we need to nebulize a patient, it's because the signs and symptoms are telling us we absolutely need to. So making sure you're being cautious and conservative with when you're doing that aerosol generating procedure. Discard it if it's obviously contaminated with blood, respiratory secretions, or other bodily fluids from the patient. Discard the respirator following any close contact with or exit from care of any patient with confirmed COVID-19. So if you're on a call and the patient says, yep, I have it, I got my test results, you need to get rid of that mask after that. Are we discarding the used masks or turning them in? You will. It's a one-for-one. So you're going to get one from your supervisor, and the supervisor is going to take your old one from you. So do not discard it. Please give it back to your supervisor. There's been some research going on right now about how can you decon these N95 masks and still keep the filter in place. John Dries actually sent me an article about putting it in your oven and cooking it for 30 minutes, I believe, at 130 degrees. Please do not use your station ovens to cook N95 masks. I don't want anybody having to do that or starting fires or anything like that in your crew quarters. But again, there's some creative ways we may be able to decon these, so we want to at least have them in the event there's a shortage, and in the event we want to go down the road to decon them either with the conventional oven and heat or potentially that UV light. Do you have a list of canister-style respirators that are N95? I do not. I do not have any lists in that, but as long as it's NIOSH approved and N95 particulate, I think you should be good to go. No, Tom, you can't put your N95 in the toaster, unfortunately. Consider use of a cleanable face shield over an N95 whenever possible. So we have some of those available. Perform hand hygiene, soap and water on alcohol after use. So make sure you're washing and using good hand sanitation after you utilize that N95 as well. We touched on this a little earlier, but I just wanted to reiterate, the county comm centers are actively screening patients. Again, it varies from county to county, but they all have some sort of screening process in place. We're working on the back end. Bob Egger has done a good job up in NEW's territory to kind of standardize how they're doing that up in that region. And I've been working on the 4 counties in our region, Wapaka, Calumet, Outagamie, and Winnebago. The big thing is, at a minimum, we want to be asking the question that's listed there. Does anyone at this address have a fever, new or worsening cough, shortness of breath, or contact with a person that had these symptoms or is known to have COVID-19? And if the answer is yes, then they're going to give that enhanced PPE recommendation, which is the standard verbiage that most of our comm centers have adopted. All right. Again, I just want to reiterate what the PPE standards are. We've had a few circumstances where we've had like 75% of the PPE standards on, but for whatever reason, the employees haven't put on the full PPE. So safety glasses are not considered appropriate eye protection, so I want to be very clear on that. Safety glasses and your personal glasses, if you have eyeglasses, are not appropriate eye protection. Goggles with indirect venting or full face shield are the only recommended level of eye protection that they can. Katie reached out to Wapaka Foundry. We're getting 20 safety glasses that have the seal around the eye that will be used as well. If you want your own personal pair of glasses, I think they're $5. Reach out to Katie, and she can put in an order for you. She's hoping to do that by the end of the day. So either shoot her a text, shoot her an email, give her a phone call, and let her know that you want to purchase your own sealed safety glasses that you can be used as opposed to the goggles. So goggles are usable. Please don't get rid of them. Wipe them down with a disinfectant wipe or spray. And then the N95 particulate mask should be worn at all times. We're not to a point where we have to use face masks. We have a ton of the surgical face masks. I know some of you have asked, can I wear a surgical face mask on every call? That's your prerogative. We have enough stock now. We got a lot from the SNS of just the standard surgical masks, the ear loop masks, that if you're one of those individuals that feels safer having that surgical mask on every single call, feel free to start doing that. We have enough stock in order to accommodate that. But again, it's not something that is going to protect you really from the N95 particulates. The trauma jackets are protecting our upper body from droplets, photos protecting our lower body. We're switching to the gowns, and you'll have to decon your pants, so you spray them down or wipe them down. that's going to be enough to decon them. Or bring with you a change of clothes in the event you had an exposure. Can we treat the goggles like the N95 as part of our uniform and just go ahead and assign everyone a pair now? That's what we're working on. Again, just the cost of it, if you want to purchase your own, feel free to purchase your own and work with Katie on that. What does our supply of megaquat wipes look like? John was supposed to get in the supply today, but we remain okay with that at this point. We don't have a ton of extra, but we have enough to get by for the foreseeable future at this point. And then just making sure you're putting a surgical mask on every single patient as well. I know there's a lot. I think Steve Radish is on the line, so hopefully maybe Steve can chime in and go through this slide on workman's compensation. Steve, are you able to provide an update on that if you're on the line? If not, I'll try to run through it. All right, hearing nothing, I'll do my best to run through this. I know Steve's been working really closely with United Heartland and Mutual of Omaha. United Heartland is our workman compensation carrier, and Mutual of Omaha is our short-term disability carrier. They have been fairly conservative with what they're willing to tell us and not tell us. A lot of it is they're waiting on guidance from the federal government on what they are going to be required to cover and what they are not going to be required to cover. Unfortunately, we as an organization don't have a lot of say in this. It's really going to come up to them and make a decision on how they're going to cover it, and it's going to be handled on a case-by-case basis based on exposure history and some other things as well. But as of now, we don't have a really concrete, clear answer for you. But again, we're working on it. We're hoping that as more guidance comes in from the federal government, we'll get some more concrete answers from Mutual of Omaha and United Heartland. And then we will certainly be sharing that with all of you once we have more. Again, unfortunately, it's kind of outside of our control, our span of control, because there are, a third-party contractor that we utilize for this type of service. So we will certainly be advocates for you guys in the field as you guys are on the front lines, and if this becomes highly saturated in this area, being potentially exposed more often, we will be certainly working with these people to do our best to get you as much coverage as we can in the event there's an accidental exposure or quarantine needed. So with that COVID-19 transport vehicles, again, Medic 2, 6, and 11, we're distributing those PAPRs. Please familiarize yourself. If you're on those ambulances, contact the supervisor. If you're unfamiliar with the piece of equipment, it should kind of be a train-the-trainer type thing right now. So if you're coming off shift and your relief doesn't know how to utilize the PAPR, please run them through that. We did identify some minor issues. Katie and John Keel are working to remedy those right now. And those should be, again, operational for transport of confirmed or patients under investigation COVID patients that we're transporting facility to facility, hospital to hospital. Couple question here. Are people who have previous conditions going to be moved away from the designated transfer trucks? We did reach out to individuals, and the supervisors have been working with those individuals to try to be creative with the schedule and get them off those trucks if they elect to want to be off those trucks. So we are aware of individuals who may want to be removed off that truck if they have an underlying condition or other things that they think put them at higher risk. Heather, if you're on the line, if you want to just provide, Heather had a brief conference call yesterday with ThedaCare specifically about direct admits. So Heather, can you just provide, I know there wasn't a lot of changes, but just give a high-level overview of that, mainly just so I can take a drink of water. Heather, are you there? I guess nobody wants to talk today besides me. So from what I understand from the meeting, nothing really has changed. as far as direct admit of patients that have confirmed COVID-19. They're still trying to determine internally if they want to send somebody down to get the patient every single time, or if we can just transport the patient up if we put a mask on that patient and have them covered up and things like that. So once we have more guidance on that, we'll let you know. But as of now, call in early, call into the hospital, and they'll guide you on what they need to do or can and cannot do. So please make sure to, again, call in early and making sure you're notifying the hospitals. They've been really proactive with communicating with us on what we need to do when we arrive. So just please work with them the best you can. All right. Future staffing issues. Again, the supervisors began daily active monitoring for COVID-19 symptoms this weekend, or last weekend, I should say. So we have a series of tests, and this came from, this came actually from DHS, Wisconsin's Department of Health and Human Services. And basically, they're asking that all healthcare workers be actively monitored by their employer. So if you have signs and symptoms, we will work in conjunction with Dr. Westfall to determine what we need to do for you as the individual and make a determination on what the next steps are after we have a trigger. As of now, we haven't, again, had any triggers of these individuals. But, again, there wasn't any individuals that have signs and symptoms right now on our roster, so just so you're aware. We have experienced quite the dip in call volume. I know those of you who have been working have experienced that and realized that. So we are adjusting right now. Medic 1 will not be operating on Mondays and Fridays, and we'll be working with the supervisors to do our best to get creative with the schedule to help adjust to the lower call volume. One of the questions here, me and Ben transferred a person to Milwaukee who, after we arrived at Milwaukee, we started to suspect of possibly having COVID. So we expect follow-up from the hospital. Is there something we should follow up on ourselves? If you get that information to Heather, send her the run number, and she can look up date of birth, and then she can reach out to the hospital. If there is a positive, we are getting notified right away. Again, as far as I know, we haven't had any positive that we've transported or any patients that were patients under investigation that have actually been tested positive. We have not had any yet. But if you have particular patients that you want follow-up on, or again, there's individuals who you suspect may possibly have it, please reach out to Heather. We're finding that some of these too, really, they're not even testing because they're considering them low-risk patients and they're not even testing. So that's why we need to continue with the active monitoring for symptoms and being proactive with PPE. We're working on kind of a more regional plan, so how we operate as a regional system, and we're looking at how do we expand that outside of our region in the event the Oshkosh Fires, Wacheras, Clintonvilles, Kaukauna ambulances, they start having staffing issues with their workforce due to illness or quarantine, and how can we really expand the reach of our regional system to cover the region we have with the resource and the ambulance services we have available in the entire region. So we're working on a plan with some of the other EMS leaders in our region to have that formulated in the event we need to implement it. Again, this was talked about last week, but in the event we are having staffing shortages, we will consider the use of mandatory overtime and shift force overs as needed, trying to steer away from that as much as we can. Current state, we have no plans to alter or cancel PLT. And then just so you guys are aware, DHS is looking at, so the Wisconsin EMS office really is looking at waiving several administrative rules that will help with future staffing issues if they arise. So creating some more flexible staffing options for us as a service will eliminate some of those credentialing issues we may have if we wanted to use some of our EMS partners in the region on our ambulances. So some of those things are happening in the background, but again, a lot of this stuff is really proactive. In the event we have a big surge in the state, the way things are currently going, I don't know if we'll ever get there, but again, at least we'll have a lot of this stuff in place. All right. And then I just wanted to reiterate this, because the state implemented the tiered system for testing, so tier 1, 2, 3, and 4, our paramedics, if they tested positive coronavirus or had signs and symptoms related to coronavirus, but they weren't testing it, we're going off of the non-testing based guideline, because most of our paramedics would fall into that tier 3 or tier 4 category, where we wouldn't get a test back for 5, 6, 7 days at a time. So to realistically sit there and wait for 2 negative tests isn't a realistic operational thing we can do. And the CDC came out with these non-testing guidelines to have for an employer to allow an employee to come back to work. So we implemented that guideline last week, and basically it says if an employee is tested positive, is under high suspicion of COVID-19 but has not been tested, they need to be at least 3 days having passed since recovery defined as resolution of fever without the use of fever-reducing medication and improvement in respiratory symptoms, and at least 7 days have passed since the symptoms first appeared. So a minimum of 7 days you'd be off, and then you need to be, in order to come back, the last 3 days of those 7 days or however long it's been, need to be symptom-free. All right, I'll open it up to any questions that anybody has. Feel free to type them in that text box on the side there, in that chat box, or if you want to go ahead and reach out, you can verbally ask your question as well. All right. It must be because I answered all the questions. Oh. Can equipped BVI ourselves be considered under the uniform allowance? If it's not something that we typically offer, so if it's not something we already standard issued everybody, we can consider that on a case-by-case basis. That $5.50, if you want to utilize your uniform allowance for the $5.50 classes, feel free to do that. I have a question about skilled nursing facilities. Are they seeing symptoms? Is the data being reported? As far as I know, there hasn't been any nursing facilities in our area that has a large rash of symptoms. I don't know what their reporting requirements or guidelines are. They'd be working with public health to determine what needs to be reported and what needs to not be reported. So the patient is found positive after transport and there was fire on scene and management reaching out to the department to inform them, yes. Either Gold Cross would specifically or the infection control team at the hospital would reach out to them. But they have processes in place for a trigger. So if a patient is positive, they would certainly reach out to us. And then even if they said they were going to reach out to the first responder group, I would be doing that as well personally. What is the difference between the flu and the coronavirus flu? I don't know if Westfall's on. I don't want to tackle that. Signs and symptoms are a little bit more severe in the elderly with the flu. Transmission's a little different, but as far as, and obviously the fatality rate is a little bit higher than the common flu as well. So outcomes are a little bit worse, but as far as overall, like we said, 90% of people who are getting this don't even require hospitalization. So the signs and symptoms that the majority of the population are seeing is not very severe. But it does sound like that when individuals are contracting it and are in that population, that older population, have other comorbidities or other underlying health conditions, that when it does attack them aggressively, it is very aggressive and it requires aggressive intervention and ventilator therapy. So. Any other questions? All right. Are we accepting mass donations from people that make them at home? at this point, we have enough surgical masks that we don't really need them. Something we could explore in the future, but they're just as good as a surgical mask. If you wanted one for yourself, I'm not going to stop you from wearing one on calls. Again, just maybe apply the tattoo policy to what kind of fabric and design you want to have on there. Make sure it's appropriate. But yeah, as far as us needing them as an organization, we're good in that area.
Oh, it's Katie's birthday today.
Oh yeah, everybody, it's Katie's birthday today. So if you haven't called or texted her, please make sure you do that. She accepts monetary and sweet donations as well. All right, everyone, I'll do the same thing next week. I'll send an invite to everybody after this is wrapped up, and then I look forward to the discussion next week. Hopefully, we kind of continue to be continue to have really not a ton to report in these meetings. So, thank you, everyone.